right. Thank you again, the organizer who invited me to share a little bit on what Malaysia has done. Not really success story, I would say, but because we are rather new to SDQI as compared to our neighboring countries. How do I change this? Oops, sorry, it's back. Okay. All right, now we started with a problem. There's always a problem first. Why we choose SDQI as a mechanism for us to tackle stigma in healthcare settings. Now we look at 2019, just about a year before the 2020 ending AIDS target, right? We can see that there, Malaysia, very much left behind with the second 90, where only 55% people living with HIV in Malaysia were receiving antiretroviral, life-saving antiretroviral during that year. So, but we were on target for the first 90 and the third 90. So we have to do something about this. And we know for sure that there are several factors leading to why people living with HIV not wanting to come forward for treatment. Number one, there are two factors, of course, the accessibility of the antiretroviral treatment, and two is the readiness of the people living with HIV or key population to come forward to get treatment. Now, for the accessibility, we know that the government of Malaysia, the Ministry of Malaysia has already provided free antiretroviral treatment since the year 2000. First-line treatment are given free for all citizens of Malaysia, but unfortunately, there are many people living with HIV out there not keen or not ready to come forward and to get the free treatment. So in part, we know there's always stigma behind it. With the stigma among healthcare providers against people living with HIV and key populations is also self-stigma within themselves. So this is something that is very complicated, and we have to look and find ways how to address that if we really want to reach ending AIDS by 2030. Now, so based on that, in 2016, Ministry of Health collaborate with CBOs and other stakeholders to come up with national strategic plan for ending AIDS. As you can see that all of us, all stakeholders agree that stigma discrimination plays important role and need to be addressed seriously. Now, therefore, you can see that and everyone has agreed that reduction of stigma discrimination must be given emphasis and focus in our national strategic plan to end AIDS. And following this, in 2018, we developed a module for the first time, which is called HOPE module. It's a module to combat stigma discrimination, but it is focusing more on awareness, creating awareness among healthcare workers, right? So it is rather, I would say, a one-off kind of training, and then hoping that people change the behavior and the attitude just by, mere training, and then we leave it. Of course, we have training of trainers at national level, at the sub-national level, and we hope that at the local level, they will continuously conduct training combating HIV stigma discrimination using this HOPE module that was back then in 2018. But as we all know, those kind of activity and program can't really change people's attitude. We have never tested whether, after following the training about stigma awareness, whether people really change about their perception on stigma. So, and we know that there has been no specific monitoring other than the community survey which we developed under MISAS, Malaysian Stigma Evaluation Surveys back then 2021. That was our very first community survey to look into the stigma level among people living with HIV. And of course, from the survey, we realized that the stigma is still there. Of course, compared to 20 years ago, it is very much lower, but there's no way we could eliminate, after what we have done thus far. So then in 2019, we were introduced by Bruce. Thank you, Bruce. Introduced to us about SND using quality improvement approach, which is something that we have never thought about, right? So all this while, for HIV National AIDS Program, it is between the program, public health divisions, HIV program, and the civil society. We have long-standing collaboration or partnership between Ministry of Health or the HIV program and civil societies under the umbrella of Malaysian AIDS Council since 1993, all right? So we have long-standing collaborations, partnership that has led to several success stories in bringing down the HIV level in the country, namely the harm reduction program, methadone needle exchange program, and also the differentiated HIV service delivery, and the latest one is HIV self-testing and PrEP, right? So we have long-standing collaboration, working partnership with civil society, but we still have not been able to tackle stigma efficiently. So this is where the quality improvement play a role, and where the QI experts, which is located under Institute of Health System Research, still under the Division of Ministry of Health, came into play, and they mainly help us in coaching, capacity building, with regard to coaching, mentoring, continuous coaching and mentoring. We talk about quality improvement. This is not about one-off a program. It is a continuous monitoring. So they provide the coaching, the training on quality improvement, while the HIV program provide leaderships and technical expertise in HIV as well as stigma. And Malaysian AIDS councils play the important role in advocacy as well as community support. So now we are stronger now with tripartite collaboration with the quality improvement team with us to help us tackle stigma and discrimination in healthcare setting. At least we start with the healthcare system first. Okay, now this is the milestones from 2019. We had our first exposure with SNDQI, and then 2020, very early 2020, we started designing our program, how we want to do this in Malaysia, SNDQI, and we had several discussions with Bruce virtually as well as in person. Then very early on, before COVID set foot in our country, 2020, it was in February. Remember, Bruce was designing. So we decided that we will select a pilot site, and we started our initial phase with 10 pilot sites, actually 11, but one of it was the major hospital that later converted into full COVID hospital, so they have to withdraw from this project. So the initial phase, the 10 pilot health facilities went on despite COVID, despite movement control orders. We went on because we were serious. We don't want to wait. We don't know when during that time, when COVID is going to leave us. So I said, no, we have to start, at least we start small, with 10 sites first. So we went on with the baseline surveys and implementation strategies for each every facilities, the 10 facilities that we had. And 2021 was just a continuation of implementation strategies. And as what Bruce said just now, each facilities will have their own team, and then they will look into the service. Each of them will look into the service delivery flow chart, or the flow of service delivery, and identify which point that raised the most stigma. And they will address one after another. Which one that gave intervention that would give the highest impact with regard to reducing stigma in each facility. So they have different priority, each facility. So 2021, actually, we observe how they do the interventions, and we re-evaluate after 6 to 8 months cycle. We plan 4-month cycle, but I think because of COVID, so we have to give them a little bit more time, 6 to 8 months, but nowadays 6 to 8 months is rather short. Okay, so and then we saw results from those interventions. On the first 10 sites, we saw good results. We saw declining in terms of the indicators I'll show you later. In terms of the attitude of the healthcare workers, they are more accepting. People living with HIV, they are more accepting key population. All right? We're not eliminating zero, but we saw declining, and those are good results. So because of those good results, though, in 2022, those year, I think 2022, the MCO, the movement control order, was lifted up totally, so we expanded to 55 additional sites from 10 plus new 55, so we have 65 sites or health clinics implementing SNDQI. And of course, this is a huge changes, it means resources from the HSR, the QI experts, plus the national program. For national program, we have no issue because we have technical HIV experts at every state or provincial level that can give guidance and technical expertise. But we have limitation with the QI experts who sits at the IHSR divisions. They don't have a branch or technical expertise at every state, but they do train healthcare providers to be expert or to be equipped with QI understanding, right? So we capitalize on that, all those trained healthcare workers to act, to give and to help in continuous coaching and mentoring. So in 2022, so we move on to additional 55, and now the 2022 phase 2 sites, they are going into the first cycle, whereas the first phase, the 10 sites already going into third cycle of interventions and re-evaluations. Okay, and then this year, 2023, we were discussing with IHSR, we have more than 1,000 health clinics, we have more than 130 hospitals. How do we expand this to all clinics? Obviously, the mechanism that we are using here cannot be applied to all clinics. So we are already, discussions already underway between the program and IHSR, looking into how best can we make SDQI and is an auto-generated program in each and every clinic. Whether we want to make it into a national indicator approach, we are not sure. We are looking into several mechanisms, how to make sure that this program get into other clinics as well, not limiting to only 55 plus 10 clinics. All right. So this is the result that I would like to share with you. Now, before I go into the changes in attitude and then fear of infections among healthcare providers and also the experience of stigma among people living with HIV that utilize the service in our health clinics, I would like also to share with you the two documents resulted from the SDQI project. Number one is HOPE module. Now, we already developed HOPE module in 2018. This is a training module about stigma discrimination. So in 2022 editions, what we did was enhancing the existing module, taking into consideration the components raised during the baseline survey, tackling the common actionable drivers. So we put it and enhance in these modules to help other clinics without or with SDQI program. So they can utilize this and they can pick and choose whichever topics, component relevant to their health clinics. So that is HOPE module. And the other one also based on the 10 sites that have showed effective mechanism or intervention that have given good results. So all have been compiled into a compendium of best practices based on the 10 sites. So this compendium, because as you know in Malaysia, the health facilities, the delivery process is more or less the same. And we realized that after the first 10 sites and the 55 sites, most of the root causes of stigma are about the same. So we use this compendium, the sharing of experience, the way the clinic conduct, and then come up with interventions. And every clinic or other clinics can actually pick and choose, adopt and adapt the tested changes, right? So these are our first compendium. So we intend to enhance with the new interventions, good interventions based on the 55 additional sites later on. Okay, and then these are the findings that I would like to share with you just based on the first phase, which is the 10 sites. I'm not going to show you the second phase, the 55, because I think they're just going into first cycle. If you look at this in general, the healthcare workers indicators, majority from the baseline, these are the interventions that they conducted and re-evaluated. First cycle, second cycle, third cycle. There are 8 indicators here. We can see majority has shown a declining pattern of negative attitude or fear about infections, right? Except for, I think, in certain indicators where it involves changing infrastructure of the clinic, which is quite difficult. All right. For example, observe care, provide poor care. Observe other healthcare workers unwilling. No standard protocols to reduce. No written guidelines. So these are something that doable, all right? So the only thing is that I think, again, at organizational level, we are planning to come up with a guideline to address the PLWHIV stigma discrimination. But actually, the code of conduct or ethics is already there. It's just that our healthcare workers don't bother to look into that, right? So what we will do is that to bring that up and then to enhance that at every facility. Okay, so this is again, the attitude of healthcare workers. We can see major changes, reduction, that our healthcare providers are more acceptable of people living with HIV and key population now, all right? Okay. Okay, this is the PLWHIV experience. We can see the experience majority from the baseline. There are still a lot more indicators that need to be addressed, but there's some issues where no privacy and confidential during visits. This is something that need to be done at higher level because it involves infrastructure amendment or changes. The majority are saying that there are 2 doctors in 1 consultation room, all right? So that cannot be held because the clinics as such, so that need a long-term decision making by the higher and top level. Okay, and then this is literacy, and you can see again the SDQI, not only that it improved in terms of the understanding of literacy or treatment literacy, U equal to U among healthcare providers, but also open up more interactions with people living with HIV to educate them about the importance of doing their treatment as well as achieving viral suppression and understanding why they need to get or to achieve viral suppress. And last, before I leave this podium, just an example of how one of the facility come up with their projects. Now they are thinking about out of the box. It's not about training about fear of infection, about awareness about stigma, because people, a lot of people, they know how the infections of HIV, but they still fear the disease, right? So now they feel that they should have projects or intervention beyond the usual patient and provider interactions. So what they did was they created projects where people living with HIV are helping and working hand in hand with the healthcare providers in the clinic, giving back to the society. So at least that would increase their self-worth of people living with HIV, especially. So they help with the healthcare workers navigating the wheelchair-bound patient in the clinic. So they are working voluntarily. So in a way, in the long run, this would create an environment where feelings would be actualized, occurring naturally throughout practice day to day. So, and this is actually a good example that I would like the other facility to also adopt, right? And of course, any program are without challenges. Always we have challenges. So these are among challenges that I think you can read later on. It's more or less the same. It's again about sustainability of the program. So we have to think about another way how to expand or to make sure that other clinics are willingly implementing quality improvements, not only for SD for HIV, but also for other service delivery. Thank you.
Thank you very much.